Here's our next case in cardiology. We're looking at a patient who says he has a weird feeling in his chest. We're looking at a patient who has intermittent sensation of fluttering in the chest. Now, fluttering is another sense of palpitations. And when the patient says palpitations, it means virtually anything. It could mean I'm in love. It could mean I had too many cups of coffee. It could mean I'm working on too many Mountain Dew commercials. It could mean that I have an arrhythmia. It can mean everything from nothing to I'm about to die of ventricular tachycardia in the next 10 minutes. So palpitations is very nonspecific, but points to the magic answer, EKG, Holter monitor. EKG, Holter monitor. EKG, Holter monitor, echocardiogram. We have a patient who has fluttering, and it doesn't mean very much, except we have a pulse that it says we are irregularly irregular. Irregularly irregular. Now, there are a number of things that could be irregularly irregular, but if you take multifocal atrial tachycardia, wandering atrial pacemaker, Wolff-Parkinson-White, Lone-Ganong-Levine syndrome, add them up all together and multiply them by 5, it's not as common as atrial fibrillation. Atrial fibrillation is the most common arrhythmia in the United States. And what is the most common risk factor for atrial fibrillation? What is the most common risk factor for AFib? Is? Cocaine use. No. Just in your case. Okay. What is the most common cause of AFib? Estrogen use. No. Except in your case. The most common cause of AFib is pulmonary embolus, hyperthyroidism, pheochromocytoma, demonic possession, asthma. Oh, yes, it does. Asthma causes it. He's got a history of asthma because asthma can cause right atrial dilation, but it's not the most common cause. The most common cause is regular, old-fashioned, boring hypertension. Hypertension, that's not very exciting. Can't I have somebody with flushing and wheezing and diarrhea who's about to have their head explode with a pheochromocytoma? Can't I have something exciting like a pheo? Boom! Sorry. No. It's regular old high blood pressure. Hypertension. Hypertension is the most common cause of AFib. So in this case, irregularly irregular, palpitating and irregular is so characteristic of AFib that it's highly unlikely that they'll ever ask you, what's the diagnosis? As a matter of fact, they'll probably just give you the diagnosis, like in this case, and say what you're going to do about it. What you're going to do about it? Huh? The guy's got AFib, and the first thing to do in AFib is decide whether or not the patient is stable or unstable. Because if the patient is unstable, you will do electrolysis on their chest in the worst way. You'll give them a waxing they'll never forget. If the person is unstable. What do you see? I see chest pain, shortness of breath, hypotension, confusion. Chest pain, shortness of breath, hypotension, and confusion. Any one of those, and you shock. Now, if the person is stable, and they have this presentation, and they're not shockable, by the way, is it synchronized or unsynchronized cardioversion? Synchronized. All cardioversions are synchronized except all cardioversions. Is that what you look like when you don't know the answer? That's so sweet. Some of you have this great look. You go like, all of them are synchronized except for B-fib. All of them are synchronized except for ventricular fibrillation because there's nothing to synchronize to. Universal fibrillatory sign. Is there anything to synchronize to there? There's nothing to synchronize to. AFib, there's a QRS that's organized. There's a QRS and flutter that's organized. In SVT, there is a QRS that is organized But in a ventricular tachycardia, there's nothing organized. So all cardioversions are synchronized except for ventricular fibrillation. So the person is stable. And when the person is stable, the next thing to do when they're stable is to slow them down. So the person to do next is to slow them if they're fast. And to slow them, you could use a calcium blocker, a beta blocker, or digoxin. Now, which one of these will slow the heart rate? All of them will slow the heart rate. Try not to answer digoxin, because digoxin doesn't work when the patient is exercising. Okay, but all of them can slow the heart rate, and all three of them, whether it is a calcium blocker, like diltiazem, or verapamil, a beta blocker, like propranolol, metoprolol, esmolol, or any other alol, or digoxin, digitalis, digitoxin, whatever, they all slow it. Now, how are you going to choose? For instance, in this patient, how would you choose? How would you choose which of those three is based on the history? Is based on the other things in the history. This guy has a history of asthma, so it means no beta blockers, no beta blockers. There has to be something in the history that tells you which one to use. Other than that, you could use any of them. You could use any of them to slow the heart rate. Now, after you slow the heart rate, and you get that person to be slowed, after you get the person to be slowed, and slow means less than 100, what's the next thing you're going to do after you slow them? You shock anybody who's unstable. So if they're unstable, unstable is easy, because unstable goes straight to shock. But if they're stable, you go to slowing them. After you slow them, what do you do? Convert. A forced conversion. You convert them. You convert them. You convert them. The first thing you do is convert them. Now, if it's less than 48 hours of duration, you don't have to anticoagulate beforehand. If it's less than 48 hours of duration, you don't have time to have formed a clot in the atrium. So if it's less than 48 hours of duration, you can go directly to conversion without having to do anticoagulation for a month beforehand. Now, if it's more than 48 hours duration, you have to make sure someone's not going to throw an embolus when you convert them. So, if it's less than 48 hours, you can go straight to conversion. And conversion can mean either chemicals, or conversion can mean electric. Conversion can mean chemicals. What kind of chemicals convert people? Lysergic acid? Methylqualone? MDMA? Conversion is quinidine, procainamide, disopyramide, the 1As. Ibutylide, dofetilide. Maricizin, propafenone. All of those. And at step 3 level, don't learn the difference. At step 3 level, don't know the difference. Don't learn the difference between amiodarone and propafenone and quinidine, because they all have the same answer for you. They are drugs that you use to chemically cardiovert someone. Don't learn the difference between those. Don't learn the difference between those. Just know that they're drugs that you use to convert someone from fib to sinus, from fib to sinus. Electrical. Electrical means that you do an elective cardioversion. You apply a little electricity to the chest and bing, they go right into fib. Out of fib, pardon me. They go right out of fib and right into sinus. So chemicals or electric. Now, if you convert them into sinus, everybody gets a month of Coumadin. A month of Coumadin. A month of anticoagulation. A month of anticoagulation afterwards, after they convert to sinus. After that seizing atrium, the seizing atrium comes back to life, you give a month of Coumadin to wait for it to come back to its normal function. Now, if it's been going on for more than 48 hours, you have to do one of two things first. You either need to give a month of Coumadin beforehand, or you need to do an echo now to make sure that there's no clot. Either eliminate a clot or dissolve a clot. Make sure it's not there or dissolve it. Make sure it's not there or dissolve it. Then you can go on to the same thing as before. Chemicals or shock. Now, at the end result is, if that you do all of this and it all fails and you're still in it failed and we couldn't get them out of fibrillation, and it all fails if it all fails and you can't get them out of fibrillation, pacemaker is a very good idea, but not so. Walk away. I agree. You're going to stay in fib? Fine. Do it your way. If you can't get them out of fib, they have to stay on Coumadin lifelong. If it fails, you have to do Coumadin. How long? Lifelong. If all fails. If all fails. Coumadin lifelong. So when you're studying for step 3, you can't go and say, gee, AFib, what's the management? AFib, what's the management? It might be shock. It might be Coumadin. It might be quinidine, procainamide, disopyramide. It might be amiodarone if they have low ejection fraction. It can't be one answer. It might be AFib. Convert, AFib, slow it, AFib, lifelong Coumadin, it depends. Did they present someone unstable? Did they present them stable and they're rapid? Slow them down. They're not rapid? They present fib that's stable and slow, go straight to conversion. They can present it to you at any one of these points. This guy is presented here. Rapid and stable. Rapid and stable. So he goes to these things first. Now, this management would also fit for SVT. This management would also fit for atrial flutter. This management would be pretty much the same for these two arrhythmias, so don't bother learning it all twice. There's no reason to learn it all twice. There's no reason to learn it all twice. Except for one thing. There's only one point of difference between SVT and all of the others, and it is adenosine. The only point of difference is that you start out with adenosine. The only point of difference is you're starting with adenosine for SVT. Before this, if someone is stable, you try adenosine to convert them and to slow them at the same time. Right at the beginning. Right at the beginning. Before you go on to this or this or this, you try adenosine only for SVT. So the issue in atrial fibrillation is, first, is it stable or unstable? Second, if it's stable, is it slow? Third, if it's slow, can we go straight to conversion? 4, I can't get them out of fib, lifelong Coumadin to prevent a stroke. Next case. I am having palpitations. Recently discharged from the hospital, being treated for an anterior MI. And during your exam, you give him the exam of a lifetime. And during your examination, ow, I told you didn't need to do the rectal in these patients. You examine him, and you kill him with your examination. You examined him to death. Now, the differential of death is basically what you see in the differential diagnosis. Any one of these things could largely result in someone being pulseless. Pulmonary embolus just being one particular type of electrical mechanical dissociation. Pulmonary embolus is just one type of electrical mechanical dissociation. So if the person is dead like this, no pulse, no respirations, otherwise known as dead, you can't distinguish between someone with asystole from someone with VFib, from someone with pulseless VTAC or pulseless electrical activity without the EKG. You can't distinguish these without the EKG. You already said that if the person comes and he's got asystole, the next best step in the management of this patient would be epinephrine, atropine, and epinephrine, atropine, and epinephrine, atropine. If they said that he had VTAC, it would be? If this guy had VTAC, what would it be? That's different? Huh? Shock or lidocaine? Huh? Is he stable?
No, it's not stable.
Is he stable or unstable? He's unstable? Why? He stays the same forever. It's very stable. He's dead. Unwavering. Never changes. The dead do not alter. So he is the worst form of instability. The worst form of instability is being dead. So you'd shock. You'd shock. You'd shock because that's the worst form of instability. That's the worst form of instability is being dead. And VFib. VFib, ventricular fibrillation, ventricular fibrillation, ventricular fibrillation, which this one is. Ventricular fibrillation, but we change the case. Ventricular fibrillation, but it says he's not breathing. Ventricular fibrillation, but it says there's no air movement. Ventricular fibrillation, but it says there's no respirations, no air movement, no breathing, no air movement, no respiration. He's got VFib, no air movement, no breathing, no respiration. So you're going to do what first? CPR. Be specific. My mother can say CPR. What are you going to do? Shock or intubate? A guy that's not breathing with VFib. You want to intubate? You want to intubate? Come on, say it. I want to intubate. Yes, come here. I want to intubate. Come here. Come here. I want to intubate. I'm sure you do. But no matter how many times it says, no breathing, no respiration, no air movement, and it says VFib, shock him. Shock him. There's nothing like being alive to make you breathe. The dead don't breathe. The living, they breathe. But I want him to die with a tube in his mouth. I want him to suck plastic into the afterlife. Yes, I know. Everybody has to have a T to O ratio greater than 1. T to O, tube to orifice. But no matter how much you want to get, at least 1 or more tubes per orifice, get that T to O ratio greater than 1. No matter how much you earn, so you might as well shock them first. Shock them first. No matter how much you say, no breathing, no respirations, no air movement. You have to chock. Then you get to intubate and epinephrine or the vasopressin. Yes, no matter how much they say no breathing, you will chock. Now, how much time do you have to leave in between each of these shocks? How much space in between each of those shocks? None. As fast as you can do it. Shock. As fast as you can do it. As fast as you can do it. Now, once you fail those 3 shocks, you give some drugs like epinephrine or vasopressin, and then you shock again. And how much time do you leave in between the epinephrine and the next attempt at cardioversion? How much time in between those? How much time? No amount of time. No amount of time. No amount of time. You give the epinephrine, you shock him again. And you give the lidocaine or the amiodarone, the lidocaine or the amiodarone, and you shock again. And you never give beryllium anymore because beryllium is a dead drug. Beryllium is with chloramphenicol and griseofulvin in the Department of Medical Archaeology at the Smithsonian Institute. And you shock again, and you don't wait any amount of time. You shock, drug shock as fast as you can. You go as fast as you can because you've got only 10 minutes to fix him. If you get this guy shocked within the first minute, you'll have a 90% chance at survival. And you kill off 1% a minute, become all the way dead. And that's why you don't intubate. If your intubation even takes 3 or 4 minutes, it means that you have killed off 30 or 40% of your patients, even if it only takes you 3 or 4 minutes to intubate, it means you're killing 10% per minute, become all the way dead. So therefore, you shock, epi shock, lidocaine shock, procainamide shock. Forget about beryllium. Beryllium is dead. Amiodarone is an alternative to lidocaine for most arrhythmias. And you go as fast as you can. Now, there's only one type of person that can be brought back later than this. Who can be brought back out here? Who can be brought back at 30 minutes, 60 minutes? Who can be brought back out here? Hypothermic drowning. Hypothermic drowning. The only exception to this is, in general, a hypothermic drowning can be brought back later. So the major issue in resuscitations with VFib is time. The faster you get it on, the better it is. When are you going to answer magnesium? When will magnesium be in your answer? And don't say tocolytic. Tocolytic? Torsade. That's right. Torsade de pointe. Twist around the point. But it's always sexier in French. Tish, that's French. Would you like to twist around a point? No, I'd like to torsade de pointe. Magnesium. Magnesium is a good antiarrhythmic. Magnesium calms down muscle. You're having premature labor? Having premature labor? Having premature labor? Having a uterine arrhythmia? Well, we need to give a uterine antiarrhythmic. Magnesium. Ventricular tachycardia? Aye. Magnesium. And you calm down the heart. And you calm down the heart. Magnesium. With torsade de pointe. With torsade de pointe. Okay? When are you going to answer intracardiac medications and squirt it directly in? When do I get to puncture your heart directly? Never. Doesn't leave very much hope, does there? All right, never. No intracardiac medications. Intracardiac medications are never the answer. Intracardiac is never the answer. When you see it in an answer, it's always wrong. When do you do thoracotomy for your arrhythmia? When are you going to answer, cut the chest open it up, and go in there? When do I get the chance to do a direct massage? When? Huh? Sit around, crack your sternum, open your chest, get my hand around your heart. When's that? During certain Aztec rituals that were eliminated 300 years ago. But with the exception of that, you don't get to do that. You don't get to do thoracotomy for anybody. Not for arrhythmia management. Not for arrhythmia management. No thoracotomies for arrhythmia management. No thoracotomies for arrhythmia management. Okay. Management of VFib. No matter how many times it says, no breathing, no respiration, shock, shock, shock as fast as you can. There's no intervals between the shock because the issue is time. Time as fast as you can. You got only 10 minutes before they're all the way dead. Time. Never give intracardiac. Never do thoracotomy. It doesn't help. Magnesium is good for any arrhythmia, but in particular, ventricular tachycardia, and in particular, the type of ventricular tachycardia that is torsade de pointe. Next case. I can't walk up the stairs. And take the elevator. A 62-year-old man with a cardiac risk. By the way, this guy has hypertension. But what's the most common risk factor for coronary disease in the United States? What's the most common risk? This guy has hypertension. But the most common risk is hypertension. Retrosternal pain radiating to the neck and the left arm that looks pretty bad. Last 10 minutes. Been going on for 5 years. Oh my God, this looks terrible. Well, except that he usually has to take 2 tablets, and here it got better with rest alone. He usually has to take 2 tablets of nitroglycerin, and here it got better with rest alone. He usually has to take 2 tablets, and here it's better with rest. So this is better than his usual symptoms. This is better than his usual symptoms. How come he's here then? If this is better than his usual symptoms. because it was more likely to cause a myocardial infarction at home than to be in the emergency department. This is better than his usual symptoms. He didn't even have to come to the hospital. He gets an EKG, and his initial EKG shows plenty of nothing on this initial EKG. This history, this physical, this EKG, the next best step in the management of this patient. Doesn't need enzymes. Doesn't need enzymes. He's got a better pattern than his usual pattern. Does not need enzymes because it's got a better pattern than his usual pattern. Who would like to do a stress test? Stress test. Stress test. Stress test. Stress test. May I take your order? Would you like that with your main course or with your appetizer? Stress test. Stress test. Stress test. Stress test is the most common wrong answer. He doesn't need a stress test. Why doesn't this guy need a stress test? Doesn't everybody need a stress test? Particularly if you own the equipment? Why doesn't this guy? Why not? What's missing here? The reason this guy does not need a stress test is because there is no diagnostic issue in this case. This guy walks into your emergency department and says, I get chest pain all the time, and when I walk up 2 flights of stairs, I take 2 sublingual nitroglycerins, I do a stress test on myself. Every time I walk up 2 flights of stairs, I do a stress test. This guy is an older, is he postmenopausal? An older postmenopausal man, not compliant with his Premarin. An older postmenopausal man who has got a major risk factor for coronary disease, who comes in and says, hi, I have classic anginal symptoms. Chest pain on exertion relieved by rest. Hi, he's got everything except a tattoo on his chest that says stenosis this way. So you don't need a stress test. You don't need a stress test because he's saying, hello, I'm an old guy with a major risk factor with classic anginal symptoms. If you get a stress test in me and it's negative, it's a false negative. So don't bother. It's kind of like this. A guy comes into the emergency room with an ice pick sticking out of his skull. The x-ray report comes to you, says it's normal. It's a false negative. No enzymes. It's better than his usual pattern. No stress test. The guy has got classic anginal symptoms. There's no point. Would you do angiography? Angiography? Angiography. You don't know what to answer anymore. Take a stab. Come on, it's a matter of scrotal fortitude. Angiography. Da, niet. You just went da. Niet. Da. Yes. No. This is like a lot of my relationships. And the answer is angiography. What will you do differently based on that angiogram? What will you do differently based on that angiogram? This guy does need an angio. He needs an angiography because you will do something differently based on that angiogram. What will you do differently based on that angio? Huh? You will decide whether not to do angioplasty, PTCA, or bypass, 3-vessel disease or left main. 3-vessel disease or left main. These are the criteria for whether or not to do bypass versus angioplasty. Whether or not to do bypass versus angioplasty. Bypass versus angioplasty. Bypass versus angioplasty. Big disease, big treatment. Hippocrates said, serious diseases require serious cures. Big disease, big treatment. Little disease, littler treatment. This is where the mortality benefit is. 3-vessel disease or left main. So the answer here is enzymes? No. Stress test? No. You won't do anything differently. Angiogram? Yes. You might cut them or you might not cut them. Treatment? What treatment will he need? What treatment will lower his mortality? He's already on nitrates and beta blockers. So what treatment will he need is aspirin. Aspirin. So in this patient, they can say, which of the following is most likely to benefit this patient? Angiography might be in the answer. If it is, say angiography. Aspirin might be in the answer. Always say aspirin for any coronary syndrome. Stress test, no. Enzymes, no. Echo is okay, but it's not as important as an angiogram and a aspirin starting. What will you do differently based on the echo? Echo is okay. Will you do anything different based on the echo? Hello? ACE inhibitor. ACE inhibitor. Based on the echo, you will either say greater than 40% erection fraction, no ACE, or you will say a less than 40% ejection fraction, in which case it will be yes ACE. No ACE, yes ACE. No ACE, yes ACE, in terms of what you'll do. This is the question to ask yourself. You get a case. Will this test change my management? Will this test change my management? It will? Get the test. It won't? Don't get the test. Will Holter monitor change his management? Holter monitor. 24-hour ambulatory EKG monitoring. Will Holter monitor change this guy's management? Hello? No. Holter will not change his management. Enzymes will not change his management. Stress tests will not change his management. Listen, you got to walk into test day knowing what the wrong answers are going to be, right? You can't expect it to be like this. A, angiogram. B, toe biopsy. C, proctoscopy. All right answers are not completely different from the wrong answers. The wrong answers have something a little bit right about them. It's hard to find pure evil. The evildoers often have a little bit good about them. It's not quite so easy, is it, to perceive? Not quite so easy. So therefore, the wrong answers have to have something a little bit right about them, or they wouldn't be in the answers. So this guy has been given nitrates and beta blockers. You have to answer aspirin. Your guy might be given aspirin and nitrates. You would have to answer beta blockers. The point is, when he leaves your hands, he should be on aspirin and beta blockers for sure, and if he's having pain, nitrates too. We don't know which one you'll get. This guy is on 2 of them already. Next case. My chest pain hurt while I was eating. My chest and stomach hurt while I'm eating. This guy is sitting around at dinner and starts to have chest pain while he's eating. This guy usually walks, and now he has pain at rest pain. This guy usually has pain on exertion. Now he has rest pain. So by definition, that means he has at least unstable angina. Without an EKG, on this history and physical alone, based on history and physical alone, how can you distinguish this patient whether or not he has an MI or unstable angina? How can you distinguish in this patient whether he has an MI or unstable angina just by the history and physical alone? How can you distinguish MI versus unstable angina? Huh? Response to nitroglycerin is the wrong and perverse answer that I'm looking for. And you'll be able to go listen for tapes, and you'll be able to tell your children and your grandchildren to listen for tapes and say, that's Grandpapa being wrong on tape in the year 2002. A claim to fame. The Lee Harvey Oswald School of Medicine. Okay? And the answer is that in these patients, being able to tell by response to nitroglycerin is precisely the wrong answer we want. because we want to be as wrong as we can now so that we're right on the test. It is good to be wrong now, so you can be right later on. The response to nitroglycerin is not sufficiently specific enough to diagnose unstable angina, MI, or anything else. Diffuse esophageal spasm gets better with nitroglycerin. You could have swallowed a nutcracker and had a nutcracker esophagus and have a response to nitroglycerin. The response to therapy is a very poor way of making a diagnosis. How can you tell by history and physical whether or not this is unstable angina or MI? You can't tell. You can't tell. You can't tell the difference between MI and unstable angina on history and physical alone. You can't tell the difference between unstable angina and MI based on history and physical alone. Now, we said that patients who have a myocardial infarction, need aspirin. People who have myocardial infarction need aspirin, nitrates, beta blockers, thrombolytics. Now, we said that people who have MIs need aspirin, nitrates, beta blockers, and thrombolytics. This guy, you can't tell based on history and physical alone. You can't tell until you have the EKG. And what tells you on the EKG that this is not a myocardial infarction? In fact, it's unstable angina. It's not ST elevation. That's the issue. Well, the thing is, it doesn't have to be depression. You see, ST elevation is what tells you to use the thrombolytics. You use aspirin in unstable angina, nitrates, beta blockers. You just don't use thrombolytics. So, unstable angina. Here we have ST elevation for a myocardial infarction. And here in unstable angina, it's not ST elevation. Now, that might mean depression. It might mean a normal EKG. It might mean inverted T waves or T wave inversions, inverted T waves. But whether it says normal or decreased ST or inverted T waves, that's not ST elevation, that's not ST elevation, that's not ST elevation. Whatever way you want to say, not ST segment elevation. And that's the point here. The management of MI and unstable angina is identical except for this one thing. No thrombolytics in unstable angina. What are you going to use instead of thrombolytics? Heparin. Heparin. You're going to use heparin instead of thrombolytics. That's what you're going to use instead of thrombolytics is heparin instead of thrombolytics. Aspirin, nitrates, beta blockers, and one other thing is used in unstable angina that's not used in MI. There's one other form of management that's here. One other group of drugs that is an unstable angina that's not in anything else. Unique, special. Another form of medication. It sounds just about like that. Agabigabee, ibidibidab, yabidabadoo. Oh, you think it sounds better than that? Which drugs am I talking about? Glycoproth, yabidabadoo, ibidibidab, hagawagaboo. The glycoprotein 2B3A inhibitors. 2B3A. And you said yabidabadoo, igabigabab. No, it's much easier than that. Not yabba-dabba-doo, igga-bigga-bab. Eptifibitide. Eptifibitide? I'd rather have yabba-dabba-doo. Hugga-wugga? No. Abscissumab. Oh, I'd rather have the yabba-dabba-doo. Hugga-bugga-bugga? No. Tirofiban. Eptifibitide, abscissumab, pyrofiban. What about Larry, Moe, and Curly? Wouldn't that be easier? No? Well, sorry, I don't make the news. I just report it. Glycoprotein 2B3A inhibitors. eptifibatide, abscimab, and tirofiban. And you got to think about what guy at the Food and Drug Administration is sitting around like this going, I had a recent drug experience, and these names came to me. I think I'll name the latest set of $1,000 a dose drugs, eptifibatide, abscimab, tirofiban, and yabba-dabba-doo. But yabba-dabba-doo is already copyrighted. So we have the next best thing. Unstable angina. You have a clot that is forming. A myocardial infarction. You have a clot that has formed. Myocardial infraction. You have a clot that has formed, that has filled up, that has formed. Unstable angina. You have a clot that's forming. Gerund, forming. Haciendo. Okay? Does heparin dissolve clots? No. Heparin prevents clots from forming. Thrombolytics don't prevent clot from forming. Thrombolytics lyse thrombi. And since they lyse thrombi, we like to call them thrombolytics. It's better than sitting around saying, oh man, I went and withdrawal from my Effexor, my Prozac, and I had a vision of eptifibatide. So things that lyse thrombi is relatively sane compared to eptifibatide. Yabba dabba doo, shamalama ding dong. So heparin is given. Aspirin prevents this clot from forming. And so the aspirin goes in here to try and prevent the clot. Heparin try and prevents the clot. But the problem is, oh no, just like in Indiana Jones and the Temple of Ischemia. In Indiana Jones and the Temple of Ischemia, the clot is forming. And Indy is stuck here in the middle of the coronary artery. And he's like, oh no, the clot is forming. Send in the aspirin. But it's still forming. I'm getting more chest pain, persistent chest pain. Oh no, I'm having more chest pain. It's forming. I'm starting to have CHF. I'm starting to make enzymes. Oh no, I'm starting to have a bad EKG. And the clot is forming. Send in the heparin. Oh no, but it's still forming. I've started aspirin, nitrates, beta blockers, heparin, but it's still forming. What am I going to do? I'm going to be crushed. What do I do? Dun, 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 dun. Eptifibatide, Riopro, tirofiban, abscimab. And basically, those drugs are alternate platelet antagonists that get in there and try and prevent that clot from forming. And they work in conjunction with aspirin and heparin to prevent the formation of that clot, to prevent the coronary artery from scrunching down. Indiana Jones and the Temple of Ischemia. And that's when you answer these. Unstable angina, not getting better with aspirin and heparin. Unstable angina, not getting better with aspirin and heparin. Group name, glycoprotein 2B3A inhibitors. Individually, eptifibatide, abscimab. Abscimab is also known as Riopro. Unstable angina. Next case. Chief complaint, hyperlipidemia management. Well, this is an educated consumer, as they say. My chief complaint? I'm here because I'm here for hyperlipidemia management. Well, that's straightforward. Takes all the romance out. And lipid management is largely going to come down to evaluating the patient on the height of which form of the lipids. Prior to going to fem-pop bypass, he doesn't have angina, he has diabetes and hypertension, but no family history, and doesn't smoke now. He's got risk factors. He's got reversible ischemia, but this guy has never had an MI, and he does not have chest pain. He's never had an MI, and he's never had chest pain. You want to look at the LDL. Now, you can make about 5 questions out of this one case. He's never had chest pain. He's never had an MI. And this guy's LDL is what you're looking at. Not cholesterol, not HDL, not triglycerides. Now, when you're going to start therapy, the answers are going to be either do nothing, diet and exercise, put the cheeseburger down. Just put the cheeseburger down. Put the cheeseburger down. Put your hands in the air. Step away from the counter. Put the cheeseburger down. Statins we have. Gemfibrozole and the fibric acid derivatives. Lower cholesterol. Fibric acid derivatives. Gemfibrozole. Cholestyramine lowers lipids. Yes, it does. And so does niacin. Now, when you are going to start medications, and you're going to start medications, you should always try and answer which one when you're going to start. When you're going to start pills, which one will you answer? Statins. You're going to answer statins. Now, it doesn't matter which one you answer. Lovastatin, fluvastatin, simvastatin, cerevastatin, atorvastatin, pravastatin. Whatever statin. It doesn't matter. But when you're going to start medications, you start statins. Now, which of these drugs will lower the total cholesterol? Which one? All of them. Very good. All of them. I don't know what that means. All of them will lower total cholesterol. But which of them will lower the HDL? All of them. But which of them will lower the LDL, pardon me, lower the LDL. Which one of them will raise the HDL? Which will raise the HDL? All of them. Which one will lower the triglycerides? All of them. So why do we want to use statins first? I don't know what that means. Why statins first is because statins lowers mortality. Lowers mortality. Lowers mortality the most. That's what the mortality benefit is. So when you're going to start medications, you start a statin because it lowers mortality the most. That's why you'll answer statins. So if I say to you that this guy has an LDL of 191, what will you say as the answer? If you say his LDL is 191, what will you do? Huh? You'll say statins. That's correct. You say 191, statins. Statins. Watch. Yep. And we make it 161. What would you do now first? Now his LDL is 161. You do diet and exercise, do nothing, statins. Statins. You'll do statins. 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 And it says his LDL is 131. What would you do now? Statins. Statins. Statins for all of it. Statins for all of it. Statins for all of it. Why? because he's got coronary artery disease. You see this where it says reversible ischemia? When you have somebody that says reversible ischemia, coronary artery disease, or ischemia, or MI, or peripheral vascular disease, or diabetes, for every single one of these, in terms of the management of lipids, they all mean the same thing. And that means for sure you'll start drugs at greater than 130. And if you don't get it below 100, you'll start drugs after a few months. So everybody who has these things, you want to be under 100. Anybody who has hyperlipidemia and can't be managed effectively and gets eventually an LDL above 100, statins, 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 statins. Peripheral vascular disease, diabetes, are considered equivalents of coronary artery disease. For sure, everyone will say statins above 130. Most people will say above 100. If you don't get it below 100 with diet and exercise, you need to use drugs to get it below 100 later on. So when you're looking at lipid management, you're looking at LDL mostly. So even though he says that his total cholesterol is 210, you're going to go and find out what the LDL is. Okay? And this guy has 138. And because he's 138 of his LDL, he needs to be on a statin. 138, 139, 149, 189, 289, or whether he's a big stick of butter ready to be spread on bread. Anything that is above 130 needs statins. Now, I said that all of these drugs lower LDL. All these drugs will lower triglycerides. All of them will raise the HDL. But if I said which one of them will lower the triglycerides the most, what's the answer? Fibric acid derivatives lower it the most. If I said which one of them raises the HDL, it's all of them. But if I say which of them raises the HDL the most, it's niacin. It's niacin. You're going to look for the coronary artery disease patient who has an LDL above 130, statins, because that's where the mortality benefit is. See you in the next case.